confirm we have about an hour. Is that right, Ashley?
That is correct.
Okay, so I'm going to hopefully take less than that so we have time to answer questions. This first slide just gives you my contact information. More than happy to answer emails or questions as they come in. Give me a call or shoot me an email. So the next slide here defines the terms restraint and seclusion, and I think it's helpful for us to just be sure that we're talking about the same thing. These terms I'm getting from state and federal laws that basically define restraint and seclusion in every setting except schools. There is no state or federal law that really addresses the use of restraint and seclusion with children in schools, and I can get into that if folks have questions. Restraint means restricting the freedom of movement, preventing someone from some physical activity or normal access to one's body. So whenever you restrict somebody's freedom of movement, you have restrained them. And they tend to fall into three general categories: medical restraints, postural or supportive restraints, and then behavioral restraints. We're going to be talking entirely about behavioral restraints, but I just did want to point out that these other forms of restraint do get used. Medical restraints, for example, are when you might be in some kind of traction device at a hospital because you've had a procedure and you need to be immobilized. Medical restraints get used in operating rooms to keep the patient in the proper position so that they can perform the procedure. Postural or supportive restraint devices are devices that get used to keep people seated in the proper position or offer them support. You might, for example, see a leg brace that stops a person from bending their leg. Those actually probably don't necessarily clearly fall under a restraint. But let's say you have you're in a bed and in order to help you sit upright, they've given you a vest restraint to make sure that you sit upright. Those are considered postural or, I keep getting this error message on my screen. The third are behavioral restraints, and these are really when we're using a restraint to impede somebody's behavior, generally because they're violent or aggressive. And behavioral restraints tend to fall also into three separate categories. The first type of a behavioral restraint are restraint used for physical force when actually someone is physically holding a person or applying some kind of direct contact, some manual hold. In psychiatric settings, we often hear these as takedowns when a person is taken down to the floor, but it could be that you, an individual, for example, is gouging their eyes out, and someone holds their arm to stop them from reaching to their eyes. That would be considered a physical restraint. We also see mechanical devices used for behavioral restraints. Historically, straitjackets would be considered a mechanical device. More common now in psychiatric settings, we see leather cuffs that are used, 4-point leather cuffs, or some kind of belts. It doesn't have to be a device that's particularly designed to be a restraint device. In school settings, we've seen duct tape used, for example, and that would be considered a mechanical restraint because you're using a device to actually do the restraint. You could also be using, we've seen belts that get used, or sheets when someone is tucked very tightly in bed to be able to stop them from moving. That's considered a mechanical restraint. The third kind of mechanical restraint are chemical restraints, and this is when we use drugs to sedate somebody or to chemically restrain them. I'm going to talk about that in a minute because this is somewhat of a difficult term, so we'll address chemical restraints in a minute. Generally, you're not considered to have behaviorally restrained somebody when you briefly hold someone to calm or comfort them, when you are providing some assistance to briefly redirect them or prompt them, and also devices that are used for transportation or security. So just addressing the second bullet, assisting to redirect or prompt, let's say you're talking about an individual that has Alzheimer's or dementia, and they're starting to move to an exit door, and someone gently grabs them by the elbow and the other shoulder and redirects them back into the facility. That really isn't considered a restraint. It's more of a prompting. Or if you have someone who, like I said, is gouging their eyes out, but by briefly touching their hand and just reminding them to keep their hand on the table, that would not necessarily be considered a restraint. Devices used for transportation or security, these are things like seatbelts in school buses are not considered a behavioral restraint if they're used during transportation. If that very same seatbelt is taken out of the bus and brought into the school and is used to tie the child to the chair, then it would be considered a mechanical restraint. Similarly, we do see handcuffs sometimes used by law enforcement in hospitals and state facilities. Those are being used for security purposes and generally are not considered, even though they are a restraint, they generally are not captured in what we call mechanical behavioral restraints. Unfortunately, Ashley, my screen has entirely lost the email comments, so if people have questions, please let me know. On the seclusion side, seclusion is defined when we involuntarily confine somebody alone in a room or an area in which they are physically prevented from leaving. And I've highlighted here the terms that are really important. The first one is that it's involuntary, meaning that they don't want to go into that room. This is not to be confused with involuntary commitment. This is really about whether the person in the moment is willing to go into the area or room where they're being directed. Generally, they are alone in the room, which means there is not somebody else who is in the room with them. And then finally, that they're physically prevented from leaving. It does not matter if the door is locked or not, or even if the door is closed, but if they are being confined in a room where they don't want to be and they're unable to get out, then they're considered to be secluded. This is distinguished from voluntary timeout, which is when someone willingly takes a timeout, or even if they're directed to take a timeout, they do in fact willingly go to take the timeout. I often describe, my daughter's 16 now, but when she was 5 and 6, sometimes I would give her a timeout in her room and she'd march up the stairs, stomping the whole way, slam her door shut. She was not secluded, she was taking a timeout. Similarly, when you restrict somebody to an area because it's consistent with the unit rules or the individual's treatment plan, this is also generally not considered seclusion. Examples of this, often at change of shift, particularly in the afternoon, you'll see that residents are expected to be in their rooms quietly during the change of shift time. It's part of the milieu program. This is not generally considered seclusion. Or if in an individual's treatment plan, they have built in some quiet time or some timeout time, that's also generally not considered seclusion. Okay, moving on to talking about chemical restraints. As I said, this term is somewhat difficult to understand, but a chemical restraint is specifically defined as medication used as a restriction to manage an individual's behavior. And it is generally unplanned and in a crisis. So just to use an example, these often are medications that are not routinely prescribed. So if you have a patient who is routinely getting Geodon, for example, that's a regular part of their medication, it's on their, they're routinely being administered it, it's being administered to treat their psychiatric condition, that's not considered a chemical restraint. It's medication that is prescribed to treat their condition. It also does not include PRNs. PRNs are considered part of a patient's treatment plan. They are given to the patient voluntarily. It's part of their medical treatment. However, PRNs are often used as chemical restraints. So you can't just look at the order by itself. It might be that a person, for example, is on a PRN for Ativan for when they become agitated, And if they walk down the hall and tell the nurse, I'm feeling a little agitated, I'd like an Ativan, that's not considered a chemical restraint. But if later on the person becomes agitated, the staff say you are out of control, you need to take a medication. If you don't take that medication, we're going to forcibly give it to you, or we're going to give it to you as a shot. Patient's not willing to take the medication. They could use that very same Ativan PRN order, but this time give it to the patient involuntarily to control their behavior. So it really does turn on, similarly to what we saw before. I'm just going to flip back. When it's sort of given involuntarily in an emergency, sort of like seclusion, that's oftentimes when we start thinking that things are looking more and more like a chemical restraint. Patient's not willing to take it. The patient is being forced to take it. It's being given specifically to address some out-of-control behavior. Often it's given as an injection. We also see chemical restraints often used in combination with other forms of restraint or seclusion. People are given an injection and then moved into a restraint room, onto a restraint bed, and or put in seclusion. So we often see chemical restraints being used in combination. This is a term, as I said, that tends to be confusing to clinicians. They tend to see chemical restraints as serving a therapeutic value as compared with other forms of restraint or seclusion, which I think we generally understand have no therapeutic value. But when it comes to chemical restraints, you're actually, in fact, getting medication in the patient that may ultimately help with their thought disorder, but it really is about the nature in which it's being given. It's generally being given in an emergency and against the patient's will. Okay, so now I'm going to move on to what we do and don't know about restraint and seclusion. And I've already touched upon the first bullet here, which is we know that it has no therapeutic value and it has no basis in clinical knowledge. And by that I mean that this does not help the patient or the individual. It is of no therapeutic value. It is a safety measure of last resort to keep folks safe who are imminently violent, but it has no therapeutic value to the patient. In terms of clinical knowledge, the basis in clinical knowledge basically is saying that there is no clinical evidence that shows that it is therapeutic. It does not positively change behavior. When you put someone in restraints or put someone in seclusion, that does not change their behavior. This is something we really are working hard in the educational setting to try to help teachers and aides understand, which is children don't learn to stop the problematic behavior because you have restrained them or secluded them. It does not teach anything. It merely keeps people safe. And actually, research shows that, in fact, over the course of time, it may, in fact, increase negative behavior and decrease positive behavior. So when you talk about a child in the school who's misbehaving, if they're put in seclusion or restraints, you may initially see a decrease in that behavior, but over the course of time, you'll see the behavior returns, and often it rebounds beyond where it was before restraint and seclusion is used. We know that restraint and seclusion are traumatic and potentially harmful to staff and to the individual that's being restrained. Studies have been done of psychiatric patients who years after their psychiatric hospitalization will recall nothing of that hospitalization except for the period of time that they were restrained or secluded. It's very traumatic for children in schools to be restrained and also put in seclusion. They have a lot of fear about being alone. Are they going to be forgotten in a seclusion room? Sense of time gets really distorted. They don't know how long they're going to be in there for, and it's very traumatizing. It also can cause injuries. People have broken bones, sprains, abrasions, contusions, and of course it can cause death. It can cause death even when it's used safely and correctly, and there have been a number of deaths, certainly of the individuals who have been restrained, but also we've seen deaths in staff members who have in fact done the restraints. Those primarily are probably cardiac events. It leaves lasting psychological scars. The decision to use restraint and seclusion is almost always, goodness gracious, arbitrary. There we go. Okay, almost always arbitrary, idiosyncratic, and generally, hold on, I've lost my place here, generally preventable or avoidable. And that, what I mean by that is that the decision to use restraint and seclusion is very individual. So if you were to go to ask, give a scenario to 50 nurses, and research has been done on this, they describe a scenario, they say, do you think that restraint should have been used in this case? The decision is completely arbitrary. It's entirely based on the staff member who's involved and not at all on the behavior that the individual is presenting. Generally, use of restraint and seclusion is based on the facility's culture to use restraint and seclusion, and really has nothing to do with the patients that they're serving. There are some facilities that have entirely eliminated the use of restraint and seclusion. Their patient population has not changed at all. What has changed is the staff culture and their reliance on the use of restraint and seclusion as an automatic response to difficult behavior versus doing other things when a patient is starting to have some difficulties. Generally, restraint and seclusion incidents stem from a power struggle between the resident or the individual and the staff member. They escalate to the point where the patient or the individual becomes dangerous, perhaps. But if the staff were to have intervened early in the power struggle and used appropriate de-escalation techniques, avoided the power struggle entirely, restraint and seclusion can essentially be eliminated. So it almost always starts with staff enforcing a rule or directing an individual to do a certain thing that the individual doesn't want to do. Power struggle ensues and things become inflamed. It's mostly used for loud, disruptive, and non-compliant behavior, but not necessarily for violence. This sort of goes to the power struggle part, which is someone's becoming loud and disruptive. I did a case recently of a young man who was bipolar. He had been off his medication. He was very manic. He was, by his own description, making rap music, which basically meant he was pounding his fists and slapping his hands on the wall to make music in a rhythm. It was loud and disruptive. Staff told him to stop doing it. He didn't see anything wrong with it. He thought he was making a pleasant sound. A group of staff members surrounded him and had an injection poised to go. When he was surrounded, he became violent, took a fighting stance, struggle ensued. Long story short, he ended up significantly breaking his ankle. And it all started not because at the point of time that they began the intervention, he was violent, but he was being loud and disruptive. And again, it sort of started with the power struggle. There may have been other ways to have gotten him to have stopped making that noise. Perhaps he could have been moved to an area where he wasn't as interfering with other activities. Perhaps he could have been given some percussion instruments. There could have been other ways to have allowed him to have had that behavior without getting into the power struggle over stop doing it. And just the last little bullet point here, generally when the Joint Commission, which is a healthcare accreditation organization, has looked at restraint-related deaths, in 90% of the cases, they have found that one of the contributing factors was lack of training of staff on how to manage a behavioral crisis, for example, like the one I just described. I used to be a registered nurse. I have a master's in psychiatric nursing, and I never took a course about how to have a relationship with a patient and how to engage in a conversation with a patient. And what this really shows is that many staff that are working in these environments really don't know how to have that kind of an interaction and aren't given the tools about how to manage a behavioral crisis. The next slide is about who is predisposed. I'm going to move through this quickly. Generally, like as I said, there is no typical patient profile. You can You can change the staff training and the staff culture. The patient population doesn't ever change, and you can entirely eliminate the use of restraint and seclusion. There are certain individuals that are at greater risk for being restrained and secluded, and those tend to be individuals that have a history of trauma or abuse. They're at greater risk, but there is no patient profile. There is the staff profile, as I said, and there's also a facility culture, and if you can change the culture and train the staff, you can entirely eliminate the use of restraint and seclusion. Conditions on use. Generally, where restraint and seclusion is used, the following conditions apply. And I would say that at the very least, schools are probably one of the places that we do not see any guidelines on use, and it's one of the areas that we're really focusing a lot of our attention, both in California and also nationally. Restraint and seclusion is only used in emergencies to prevent an imminent risk of physical harm. It's only used when other less restrictive alternatives have failed. It can only be used for the least amount of time necessary and in the least restrictive way. Now, this is what the law requires. Certainly, we don't always see this in practice, but this is what the law says, which is it can only be used in an emergency. It can only be used to prevent physical harm. Property damage alone is not sufficient. So if you have an individual who is swinging a baseball bat at a computer screen and no one's getting hurt and he's not using the shattered computer as a weapon, then you can't restrain. Other least restrictive alternatives must have failed or at least have been determined to have been, will not be effective. And again, it can only be for the least amount of time necessary and in the least restrictive way. We in California see this as a problem. We see a lot of use of 5-point restraints, mechanical restraints, which means tying all 4 limbs down and then also usually putting a 5th restraint either across the chest or across the hips. When I first got started in psychiatric nursing decades ago, we often would see 2- and 3-point restraints, and now it seems like everyone's moving to 5-point restraints. And one of the things I really challenge them on is, why do you need to restrain 5 points? What is really showing you that level of restriction is required? Restraint cannot be used for coercion, discipline, convenience, or retaliation. I think these terms are pretty self-evident. We oftentimes see certainly chemical restraints being, I would say PRNs are offered, and when a patient declines the PRN, they're told you can either take it voluntarily or we're going to give it to you. That certainly is coercive, but it's actually more coercion towards using the PRN. It's a sort of a threat. The next is that only staff who are trained are supposed to be able to apply restraints, and they have to be currently trained, and they have to just demonstrate competence in that restraint. There are a number of restraint training programs that are out there, some more reputable than others. They all require periodic retraining, and programs that really move away from restraint and seclusion do training all the time on components, primarily not on how to do a takedown or how to apply a restraint, but really about ways to avoid using restraint. Generally, a physician's order is required to restrain or seclude a person. In an emergency, registered nurses generally can do this. It can never be written as a standing order, means you can't have in the chart restrain as needed when needed. It can only be used in an emergency. You have to get the doctor's order immediately, and generally those orders are for a limited duration. In most settings, the doctor needs to come in at some point and look at the patient face-to-face, or perhaps a specially trained nurse or a physician's assistant. And there are always requirements about the level of monitoring and observation that staff need to be providing the individual when they are restrained or secluded. These are where you can find the standards. There's federal law, there's state law. I mentioned the Joint Commission, which accredits many healthcare facilities, and generally the standards cover the elements that I've included on the right side. We do have a somewhat abbreviated publication available on our website that is in the table form and generally talks about what state law and federal law, California law and federal law are around the use of restraint and seclusion in various settings. So I want to now talk for a few minutes about what we can do to avoid the use entirely. I think this is really most important. As I said, we know of a number of facilities that don't use restraint and seclusion that used to, and there are a number of core measures that have been, core elements that have been proven to work. 6 core measures, and I've added a 7th. But generally what you have to do is change the culture of a facility or organization from a culture of control to a culture of patient or resident empowerment. And that culture change really starts at the top with top leadership. That leadership has to create a vision and a culture that really prevents that conflict that can result between staff and patients, that really avoids violence and respects people's personal liberties. So it really is about changing the entire culture. It means granting staff members. Many of these facilities are very rule-bound, have a lot of rules, and a lot of those rules are there for staff convenience. And culture that moves away from using restraint and seclusion really takes a look at all of those rules and decides which of those rules are really necessary, and eliminates as many of the rules as they can. So I talked earlier about, patients needing to be put in their rooms at room time during change of shift. That really is for staff convenience so that the patients are out of the way and staff can meet and do the change of shift, sharing of information. But many power struggles get started over, you need to be in your room now, you need to stay in your room, you can't come out of your room. And really the patients are in their rooms not because it's therapeutic for them, but because it's convenient for staff, and really taking a look at whether any of those rules really need to be enforced, because what you're setting up is these power struggles. The next is being sure that you have sufficient staffing and you have sufficient programming. You have enough staff that can engage with individuals individually and not sort of do large mass groups, and that you also have enough programming that really is interesting and engaging and keeps the residents busy. You also have a culture that really keeps the focus on the use and continued decreasing use on restraint and seclusion, and makes it a constant priority and a constant focus. And this is really, like I said, it needs to come from top leadership. It needs to come from top down. They need to set the example, they need to walk the walk and talk the talk, and they need to devote resources, and they're best positioned to devote resources where they can be to avoid the use. The second component is a facility that moves to really integrating principles of recovery and trauma-informed care. And these are buzzwords that actually have a lot of meaning. I don't want to divert us too far from the topic. I think I do have a slide later on that talks a little bit about trauma-informed care. As I said, what we know is that most people who are victims of restraint and seclusion have a history of trauma. They have or abuse. And what we know about people who have a history of trauma is that there are changes in their brain that make them have a very heightened flight or fight response. They may perceive what are pretty innocuous interactions as being threatening, and they respond with a heightened threat response. And so if you can move to a program that really embraces trauma-informed care and avoids those power struggles and is very sensitive to the individual and the individual's needs, then you can generally have a much more calm, caring, and restraint-free environment. Principles of recovery really go also to how much you include the individual in his or her treatment planning and in directing their care. This sort of circles back to the idea of power and power struggles. Let's use the example of the man I talked about earlier who was making rap music on the walls. Why do we have to say he can't do that if that's a part of what is helping him in his recovery? Can't that be integrated into his treatment plan in some way so that he can use that as an outlet, as if it is an outlet for him to calm? Let's sort of work with the individual about their own individual recovery and what helps them in their recovery. The next core strategy is to implement restraint and seclusion prevention tools and alternatives. So we are going to have folks, all of us, me included, have moments when I'm not at my best and I can feel myself escalate. And we all individually have things that we do to help us calm, to help us de-escalate, and to really make those tools readily available in these facilities and to the individuals. The first thing is at admission, or when you first have an interaction with an individual, to develop a trauma assessment form that lets you know that this individual might be at heightened risk. Along with that, you want to develop a crisis plan. You work with the individual to say, what are some of the things that trigger you? What are some of the things that make you upset? What are the things that help you calm? And let's try to really develop so that those are available and that you can have ready use to those. All of these individuals are in facilities or in programs where we should be helping them develop strategies that they can take out and use when they engage in interactions out in the community that can be upsetting or irritating. And so part of it is really helping them develop an individual plan for when they can start feeling themselves become agitated or upset. What are some of the triggers that they know upset them, and what are some of the individual things that they can do? I really like to exercise. I like to get out and take a walk. I like to go to the gym. Some people want to be still. Some people like quiet and silence. Other people want to hear loud, hard rock and roll music. Some people like to color. Some people like to journal. There are a lot of sensory modulation tools that we see used. Squeezy balls, vibrating pillows, leaded vests. I don't know how many of you have gone to the dentist and had them do an x-ray and they put that leaded vest on you when you're sitting in the chair. And there is something calming about having the weight of a lead vest on that can be very calming. I've seen pipe cleaners where people can, fasten different things. All kinds of sensory modulation tools that are out there to help folks. A number of facilities have redesigned their seclusion rooms into comfort rooms. There's a whole industry out there now about how to, paint the walls, put in fish tanks, put in rocking chairs or gliding chairs, bean bags, to really make them be calming sanctuaries. I went to a state facility that serves people with developmental disabilities, and they had like an indoor Zen garden where they had wallpapered this really beautiful greenery on the walls. They had one of those drippy fountains, some very quiet music, soft lighting, and patients were invited to go in there at any time that they wanted to calm and to quiet. And so these are some of the tools that we see. A number of programs have these in sort of like a crash cart mode. So they have a bunch of sensory modulation tools that they've put on a crash cart or in a little crash baggie. And then when a patient is starting to escalate, you bring that bag of goodies to the individual and offer them a variety of sensory modulation tools that they can pick up and use. And what is going to help them, what's going to help them calm. The next is workforce development. This is really working with the staff. As I said, teaching them how to build relationships. How do you avoid power struggles? How do you interact with individuals? That this is part of what's been built into their training program. It's built into their staff competencies, and it's built into their performance evaluations so that you're picking up on when staff are having difficulty, and you're doing ongoing training with the staff members, not point-in-time training. And by that I mean, as I said, most facilities do require staff who do restraint and seclusion to be trained and to know how to do restraint and seclusion. Most of those programs require staff to go through refresher training every 2 years, and a lot of that training program is really about de-escalation. But being trained in something every 2 years does not sustain. It really is important to do that training ongoing. And facilities that have moved away from using restraint and seclusion make it a regular part of their weekly staff meeting or monthly staff meeting. They train in a particular component. When there's been a restraint event, they use that as an opportunity to look at a component of the program that maybe needs some additional training. Really give your workforce the tools that they need. The next is to really vigorously debrief every incident, and do this with the involvement of senior management or senior administration. These should be remarkable events. Sort of like the death on an operating room table. If you've gotten to a place where you need to lay hands on somebody, you need to restrain them or seclude them, something went horribly wrong. These are safety measures of last resort. They should only be used when an individual poses an imminent risk of serious harm to themselves or to others. We should see these incidents coming, and we should be intervening early to prevent them from getting to that place. And so if you have ended up with a restraint or seclusion event, you need to use that after the event to go back and say what went wrong. And not just look at the moment in time where the individual has taken a fighting stance, but really going back in time to say what was going on for the individual that day, what was going on for the individual 2 days before, 2 hours before, 15 minutes before. What was our interaction with that individual? Were there things that we did that escalated them rather than de-escalated them? If they have a crisis plan, and all these folks should, did we follow the crisis plan? If we didn't, why didn't we follow the crisis plan? And if we did follow the crisis plan and the crisis plan didn't work, then we need to revise the plan, because obviously what we had and what the individual has designed to help them calm didn't work, so the plan didn't work. Generally, these debriefings should be happening within 24 hours of the event. Best practices are really you do a mini debriefing of the whole unit or the whole milieu, because when there has been a restraint event, it escalates everybody. So you might bring the community together and have a mini process, but the actual rigorous debriefing should happen within 24 hours. The individual should be participating in that, and as I said, you need to also bring in senior management. The next key component is really looking at data and publicly posting that data. Data really informs practice, and looking at what your data is showing. So by that, I'm talking about not just how many incidents you've had and how long they've lasted, but time of day, day of week, what staff members were involved. Do they always happen at lunchtime? Do they always happen on the evening shift? Do they always happen when people are waiting in line to get their medicine? Those give you opportunities to see where it is that your program may need to be revised, but really looking at data to inform practice. And by putting that data up publicly, this has been a component that folks have seen. It really engages staff members. People want to see the numbers dropping, you can compare data on different units or with sister facilities. It not only engages staff in a healthy competition, but also if you see one facility is really doing much better, then you can go to talk to them and say, what are you doing? What's different? What have you changed in your program that we could start embracing in our program? And the last key component is to actively involve consumers and family members. They often are left out of the process. It seems like it's an us or them culture. And oftentimes the consumers can tell you what is going on in the program that is not working for them. What is not working? I'll give you an example of a state hospital in another state where the executive director told me that patients were giving him feedback, and they said, you know, every day of the week we have to get up by 7 because breakfast is at 8. And how come on Sundays we can't sleep in? Why can't we just have a breakfast buffet on Sundays? We sleep in until whenever we wake up, and then we just are able to kind of wander to the breakfast buffet and pick and choose what we want. Why do we have to get up on Sundays too and have an early morning breakfast? And it just was an aha moment for him. We all like to sleep in on Sundays or one day of the week, and we don't always have breakfast at the same time. And to get the feedback from the patients about that really was very informative for him. Another one was oftentimes facilities will turn off the phones from 11 at night till 7 in the morning. And really that's based probably on staff convenience and also the fact that they don't think that patients should be making calls at that hour of the day or night. But there's no reason why a patient shouldn't be making that kind of a call. It sets up a rule. So really engaging with consumers around those things. Some facilities have moved to involving peer advocates, and by that I mean discharged patients or folks from the community that have are peers to the consumers. They come in and they participate in debriefings. They actually sit with the individual and are sort of like the person's advocate and give them some support and give them a voice in either participating in the debriefing programs. Also involving peers and consumers at every level of facility committees and in facility positions. And this is, again, really about breaking down that culture of us versus them. It really is including if you're talking about a facility and there are staff and there are patients, then there ought to be staff and patients in all of the facility committees and in positions, and not just token positions, but really engaging them. It not only helps the facility recognize some of the opportunities where they can involve the program, but it also really breaks down some of the bias and stigma that staff can inadvertently carry around about the health and involvement of patients. It really breaks down those cultural barriers when you are joining with patients or consumers in talking about how to work together in a program or in a facility. Lastly, I just want to talk for a few minutes about the principles of trauma and trauma-informed care. It might be a topic that you would want someone to come and do an entirely separate training about, but there has been a lot of work done in the area of trauma and trauma-informed care. What we understand about these programs is that they really have an understanding about the vulnerabilities of people who have been traumatized and what are the triggers of trauma survivors that can just be in a traditional service delivery system, and then designing a program that really is supportive and avoids trauma. As I said, there's been a lot of research done about how trauma affects the brain, and by trauma, I don't mean that you necessarily, are a war veteran, returning military, or, a survivor of horrific child abuse. Some of the folks that have very significant trauma may, in fact, have witnessed one particular traumatic incident. I actually, this week, have been thinking about everyone who's in Oklahoma and who has gone through that tornado. They are all victims of trauma, and I am pretty sure that any time in the next few months or maybe even years they hear a wind starting to blow, they're going to have a heightened fight or flight trauma response based on that. I had a family who was at the Boston Marathon. We're only a block away from the bombings, and I recently had dinner with them, and they talked about in the days after there was some work being done across the street from their house. They were doing some drilling and some banging, and every time they heard those noises, the banging, they both jumped. Now, it was a heightened response. They were able to think, oh, that's right, that's just construction next door, but they had a heightened response to that sound based on the experience that they had had. And we need, people who have been victims of, people at risk of restraint and seclusion are often folks that have a history of trauma, they have a history of abuse, and so we really need to be, programs that move away from using restraint and seclusion are very sensitive and sensitized to all of the components of their program that might inadvertently be re-triggering of that trauma. It's about respecting individuals, keeping them informed, keeping them connected, keeping them hopeful about their recovery. It's interacting with individuals in a respectful way, offering dignity. We have to work collaboratively with these individuals and folks we serve, learn together about how you can work together versus, quote, helping, which might be that one individual has an agenda of what they want to do with the other person, really fostering the relationships between folks instead of just working on an individual, and really responding with hope, being caring, patient, and supportive versus reacting out of fear in a rule-driven, reactive, and restrictive environment. When I talk to some facilities about some of the rules that they have, they often will tell me, well, we have that rule because one time one patient did this one thing, and now they have a rule about that for everybody. And that is really reacting in fear rather than developing an individualized, caring, supportive environment that serves the individuals, meets them on an individual level. So that concludes my formal presentation. I'm happy to answer questions or to speak specifically about any particular topic that folks may want me to.
Thank you so much, Leslie. That was wonderful and very educational. Regarding earlier slide in the very beginning, there was a question on what is a PRN?
I just had a feeling I was going to ask this. A PRN is a Latin term that basically means as needed. So there are two types of medications that generally are prescribed. One is you're getting your medication on a routine basis. So let's say you have a patient with bipolar disorder and they're on lithium and they take that lithium every day. That's a standing medication. Then periodically they get a headache, and there might be, all of us take Tylenol or Advil or Excedrin as needed for our headache. Those are PRN medications. And for patients that have a history of agitation or upset, we often will see as needed medication, PRN medication, used to help that individual calm as needed. It's not something they take every day or twice a day or once a week or once a month. It's something that they take only as needed to address whatever the symptom is.
Thank you. What do you recommend for a person in a restraint seclusion situation that triggers a claustrophobic reaction?
Well, my first thought is they should not be put in restraint and seclusion. And you really need to work with that program or facility about how to avoid it altogether, because if a person is claustrophobic and you're putting them in a claustrophobic environment, they're going to fight it. It's no longer about the underlying incident that got them there. They're now onto a whole other incident, which is it's triggering for them the feelings of fear and panic. And so we really need to be looking for how are we, let's eliminate restraint and seclusion with this individual, and let's really come up with other ways that we could be intervening early so they don't get to the place where they even need to be in restraint and seclusion. I often work individually with facilities or individual programs about what is this person's unique triggers. Do we even need to be using it? So many times I see restraint and seclusion used, and it really isn't necessary. Individuals who wander or AWOL or need to get out and take a break. Well, is there any reason why they can't go out and take a break? Is there any reason why they can't sit outside on a swing or take a walk or just get off the unit for a few minutes or wherever they are? So I would really be looking at why are they using it, and I would say particularly for an individual who's claustrophobic, it's contraindicated. It should not be used because it's having the opposite effect. It's not keeping them safe, it's making them worse.
Thank you. How should a patient handle a situation in which he or she is mistreated by a staff, for example, being pushed to the floor and kicked? How does she secure evidence if they want to file a complaint, and how can they avoid being mistreated because they are mentally ill?
Well, that, again, I don't know where the caller's calling from, but that certainly in California and in most states is not just being kicked, that's a battery, and it's a crime. And when it is a staff member that's doing it, it's a criminal abuse. And so I would, certainly in California, it is required to be reported. It should be reported to not just the facility, but also to outside investigators. Now, I have to tell you that these incidents often don't really attract to the attention of law enforcement, and certainly district attorneys don't prosecute them, but we need to be reporting this. This is abuse. Unfortunately, often it does get down to a he said, she said kind of a thing, and unfortunately there's a huge bias and stigma against patients with mental illness, and a lot of deference given to the nurses and the staff that are paid to, quote, care for them. So I think that it's important for the individual to immediately make a record of what happened. It certainly helps if there were other witnesses that were there. Get injuries photographed, get injuries assessed and documented, make the facility do an investigation and offer an explanation for how that injury occurred. Oftentimes, the injuries are inconsistent with the explanation offered. I was doing a case about a year ago of a young man, 30 years old, very healthy, very physically fit, and he described being put in a wall restraint, and he had 3 ribs fractured in the wall restraint. And he said that the staff members punched him repeatedly in the torso and broke his ribs. The staff documented that he had 3 rib fractures, but could offer no explanation for how those rib fractures occurred. And really, rib fractures are a trauma injury, meaning it's because of some sort of a force. His explanation rang true. There was no documentation that he had fallen on a bed frame or a door handle or a chair. No other explanation for how he possibly could have had those 3 rib fractures occurred, except from the way that he said that they occurred. I don't know if that helps.
Yes, thank you. Some patients use self-injury, mild forms, as a coping skill to calm themselves. Should this be allowed in an inpatient setting?
There is just a lot of research out there about self-injurious behavior, and there are many less restrictive alternatives that we could give these individuals so that they can have the experience of being self-injurious without posing the risk that facilities are often fearful of. We see a lot of self-injurious behavior that ends up in a restraint or seclusion incident, and I think that it's because the facility hasn't really thought outside the box about ways to tolerate the risk of the injury, and instead they get into a restraint and seclusion struggle. And in the end, we have not really given the individual an alternative for the distress that they're feeling. Many folks who are self-injurious describe getting relief from the injurious act, and it is their coping mechanism, and until we can give them another coping mechanism, they're going to continue to do it. I know that, for example, with women who are cutters and like to cut on their wrists and arms, there was one facility that gave women stiff loofahs, those really hard sponges with kind of a hard edge to them, so that they could have the experience of inflicting some discomfort. They could do it on the very place where they cut themselves, but did not pose that kind of a risk. There's a lot out there, consumer movement driven stuff from people who have been self-injurious that can offer a lot of different suggestions about ways that we can teach consumers how to not be self-injurious, but also sort of tolerating some of that risk.
Thank you. The next question is, as an attorney, when you get complaints about restraint seclusion, who is it that normally makes that complaint? Ombudsman, RN, client, family? It seems facilities and personnel would be reluctant to report out of fear of losing their job.
We almost entirely get complaints from the individuals or family members. Rarely do we get complaints from staff or the facility. And when we go in and we do these cases, I think because of the experience and expertise that I have, I'm often able to work directly with the facility because they don't like doing these either. Staff get hurt. Staff are traumatized. These are traumatic events for everyone involved. And we sort of get our foot in the door on one particularly bad incident and then able to really work with the facility to say, let's get you to move away from this. Let's take a look at how you're doing your treatment planning. Do you have crisis plans? Do you have sensory modulation tools? Do you have good data? Let me give you the tools that you need to move away from this. There's a lot of research that's been done recently about the cost of doing restraint and seclusion to the facility. The manpower, most people who are in restraints or seclusion are on a one-to-one. There's heightened documentation. You have to bring doctors in. It's very costly. Facilities that use a lot of restraint and seclusion have a huge amount of staff turnover. They have staff injuries, which results in workers' comp costs. If you have staff turnover, you have to do hiring, you have to do training, and that's a constant cost. You have an environment that's very hostile and negative versus a restraint-free environment where staff want to work there. And so I've been able to work successfully with facilities once we get our foot in the door in a particularly bad incident to say, let's really work together about how you can move away from this. Wouldn't you like to not do this anymore? I worked for years with a school, a couple of years with a school, and just this past month, the executive director, it's a non-public school for children with psychiatric disabilities. It's actually publicly funded, but it's sort of a segregated school. And the executive director sent me a picture of the very last seclusion room door that they had taken off. And he said, you were the person I wanted to share this with. And when I first went in and did an investigation in his facility, he didn't like me being there. I didn't get it from him. I got it from the father. And over the course of time, I did a lot of training with his staff. And he was just delighted that they have moved away from this. He's a businessman, and he can see how his business has changed because they don't have to do this practice anymore.
Thank you. Where facilities have eliminated restraints and seclusions, do you have a sense of what the drivers were that prompted this? What is the role of consumer campaigns, etc.?
I think that, to be honest, I think the drivers are executive leadership. I don't know of very many programs that have eliminated restraint and seclusion without having the executive director absolutely committed and behind the effort. You're talking about changing the culture of a facility. It's a paradigm shift for the facility. You have a culture of staff and of patients that are accustomed to this being the way business is done. And if you're going to change a business model or a business practice, it really is going to take the commitment of the senior leadership and the executive director to do that. Now, having said that, having the involvement of peers and consumers is a critical component. But if I were to be honest, I would say that the programs that I've seen that are successful in eliminating restraint and seclusion, it's because they had the commitment of senior leadership. Many of these programs, when they start eliminating these practices, they actually see a spike in restraint and seclusion, and you have to have a business or an executive leadership that knows that that is going to be a short-term problem, but if you can ride people through it, you can move to eliminate it. So you need to really have the commitment of top leadership to really make this successful.
Are there any standards imposed on county jails? May the jail staff kick the patient, remove all their clothing? May the court prevent the mentally ill person from being examined by a non-jail physician?
Wow, this is really a little bit beyond the scope of what we're talking about today. There are rules about, in jails, there are rules about what guards can do. Certainly they can't kick and punch a patient. That would be against the law, just like it's against the law anywhere. Getting into jails and prisons is a much more difficult environment, and they really do, they blur what we're talking about in terms of behavioral restraint and seclusion with some security practices that really fall outside. So for example, we talk about seclusion. Jails talk about administrative segregation, which is when you put an inmate in a cell by themselves because they are dangerous. That really, if you were to do that in a psychiatric facility, that would be seclusion. But in a jail setting, it's part of the security measures that are, quite frankly, acceptable practice in some areas. So these are very, it's a much more difficult area to navigate when you're talking about in a jail or in a prison setting. Similarly, you see handcuffs used for security measures, and yet we also know that restraint and seclusion get used. So I can't really speak to searches and same, having searches done and who should be performing those searches. It's a little bit beyond the scope of what I was prepared to talk about.
Yeah, thank you. We have one final question, and it is, could you suggest where to find the consumer-driven alternatives for self-injury?
Yes. How about if, can I send that to Ashley, and Ashley, you distribute it? There's a woman who's got that information, and I'm not sure I'm going to be able to quickly put my fingers on it as I'm here. I'm quickly trying to find it. But could I give it to Ashley, and Ashley, you could distribute it?
Yes, absolutely.
Okay.
Okay. And so everyone can contact me if they would like a copy of that as well. So thank you so much, Leslie. We really appreciate you taking the time to be with us today.
Yeah, well, thanks for having me.
Thank you. Bye-bye.
Bye.